Hello, everyone. Welcome to the Pain Consultants USA podcast, a podcast from the founders of PainConsultantsUSA.com, a telemedicine company with the mission of restoring the patient-physician relationship while redefining medicine. Pain Consultants USA aims to do this by increasing patient accessibility to high-quality musculoskeletal and pain specialty care while decreasing patient costs. Their foundation is built upon patient education, care coordination, and multidisciplinary treatment. Now here's Dr. Connor and Dr. Bonner.
Good evening, everyone, and welcome to episode 6 of the Pain Consultants USA podcast. Today, Dr. Bonner and I are going to be talking about how a common cause of back pain could be coming from the joints in your low back, called your facet joints. So, Dr. Bonner, uh, can you maybe start us off by just telling us exactly what is a facet joint and
Yeah,
kind of
absolutely.
describe things?
Good to talk to you as always. So, the facet joints are kind of, or what we call the zygapophyseal joints, or Z joints, is what you might refer to them as. They're paired joints that are on the posterior part of the spine. So, I have my trusty spine model for those watching on YouTube here. So, the front part of the spine is over in this area, in front of what's called the vertebral bodies here and the discs. Okay. And then the posterior part of the spine is back here. These are the spinous processes, these big bony things that stick out. And then on each side of those, I'm going to turn the model to look at the posterior part of the spine. We see paired joints. So one joint on each side. So one here, and then the same thing on the opposite side. And we see two joints at every single level there. Okay. And those help to function to regulate motion in the spine. And we know that sometimes these joints can become painful, and they can commonly be a cause of chronic low back pain, especially as we get into the older population. We see that much more commonly. So I think we talked about the lumbar disc previously causing a lot of pain in younger people, but we tend to think more of these facet joints in the older population. Not that it can't happen in the younger population, but just more common in the older population.
Yeah, that's a great description. And, I'll try to tell my patients that think of them almost like a little knuckle. These joints are very tiny, and you have them from the base of your skull all the way down to your sacrum. And exactly like you said, they help to determine motion. Um, and as you go through life, just like you could get some arthritis in your knuckles and hands, you get arthritis in the spine. It's a little more tricky or challenging to try to figure out if that arthritis in the spine is actually causing pain compared to maybe a knuckle in the hand. But hopefully, we'll get into some of that here tonight as well.
Yeah. Yeah, I guess another thing we should mention is that although these joints are very small, they do, if I could find one that maybe opens a little bit right here. So we find that actually on the surface of each side of the joint, there's the cartilage, just like there's cartilage in your knee or your hip or your shoulder. And it's very small, but there's still a layer of cartilage there. And so when I talk to patients about cartilage, because I think, it's easy to understand that bones meet to form a joint, but then it's hard to think about, okay, that bone is actually covered by something inside that joint. And cartilage is what kind of functions to make the joint very slippery. And so when a joint moves, there's very little friction in the joint when it has a good coverage of cartilage. I like to describe it as like two kind of cubes of ice rubbing against each other, that it's just very slippery. But as you get older, you tend to lose that cartilage, and as you lose the cartilage, you can then have exposure of the bone, and then you can have what everyone knows about bone on bone arthritis. That's a really bad form of arthritis when the cartilage is kind of completely degenerated and can sometimes be very painful. So when we talk about arthritis, we're talking about generally kind of other changes related to mostly aging, and sometimes other things cause arthritis, of course, but most commonly aging. And we talk about losing the cartilage covering in the joint and then making the joint movement less slippery.
Yeah, and you make a good distinction there with regards to, the wear and tear type arthritis as we go through life, where you lose the cartilage, versus, something like more of an inflammatory condition that, is causing an active inflammation within the joint, which I think we'll probably touch on here tonight as far as, what those treatment options may be for each of those types of scenarios. Um, One of the other things I think we should mention with regards to the joint themselves is, okay, so you have arthritis in the joint, it might be bone on bone. Well, how does your body know you have pain from there, right? So the body senses pain because nerves send the signals to the brain, right? And we interpret that as pain. Uh, and that happens everywhere in the body. So the facet joints are no different. So on this little model, we have, if you can see here, I drew these little black lines with on the model. So the black line actually indicates a little nerve called the medial branch. And each medial branch, if I can kind of highlight here, so this little black part here, right, it will send pain signals from the joint to the brain. And each joint gets innervation from the two medial branches. And depending where you are in the spine, the terminology may be different. But in the low back, it would be so this joint would get it from uh, the medial branch above and at that level. Um, that becomes important when we talk about potential treatment options for joint pain that doesn't respond to physical therapy, maybe some manual manipulation, and just conservative treatment.
Right. And I guess the other thing to talk about in relation to that is then how do we identify this pain in a patient? So what do we see commonly in a patient? Where is the pain? Do you have like a typical patient you think of when you think of a patient with facet joint related pain?
Well, with I would agree it's more common, or I think of it more commonly in patients who are a little older. Um, might be the typical patient who, um, they might say when they wake up in the morning, they complain of some back stiffness, gets a little better as the day goes on or with some activity. And once they get moving, doesn't necessarily have to radiate down the legs. It might have discomfort at the belt line and into the buttock, maybe a little bit into like the upper back of their thigh. Um, uh, and I think we classically think of patients saying, "Oh, it's worse when I kind of arch backwards rather than go forward."
Right.
Um, but it's usually like the whole story. So if it
Yeah.
sounds like, you know, stiffness in the back, discomfort once they get moving, feel a little better, doesn't radiate down the leg, that's some of those kind of keywords or kind of get my signals up that we might be looking at facet issue. How about yourself?
Yeah, I think you hit on a lot of the major points there. We do know that you can get pain all the way down the leg, although it's probably much less common than some of the other causes. Um, we know that there's been no great study ever to show really any physical exam or historical findings that really correlate with nailing down where this pain is coming from. But we still all use a lot of these tools. Like you said, is it hurt more when you bend over or lean backwards? For some of these patients, it might hurt more when they bend over because there is some stretching of the joint capsule that happens in those cases. But also, you can imagine that kind of leaning backwards. If you show the model here, if you lean backwards, I can't arch this, but it would put a lot of pressure on these joints that are right back here. It squeezes them together, and you can imagine that that would be pretty painful in someone with painful arthritis of the facet joints there. So, some range of motion would definitely be painful, probably. And then, like you said, I think it's the first thing I think of in older patients. And, I'm pretty much, when an older patient comes in, I'm pretty much thinking that and then trying to, rule out other things. But I think that's, generally what we're thinking of there. Um, I tend to use palpation as my guidance for where I think which joint it's coming from. So I try to find the point that's most tender on the patient's spine to see what level I think the problem's coming from. Like we said, there's two joints at every single level. We know that if it's on one side, the pain tends to stay on that side for the patient. It can be bilateral, and you can have bilateral painful arthritis at the same level at the same time. But usually, if it's one sided, the pain will stay on that side, and then usually the pain will radiate kind of out to the side and then down. It doesn't tend to radiate up. So I'll tend to try to palpate where it's kind of most painful and kind of use that as my guide for what level I think the pain might actually be coming from.
Yeah. So in those instances, there'll be discomfort where you're pushing. Maybe the muscle in the back might feel a little what we call hypertonic or tight. Um, yeah, from my standpoint, I also know on examination, definitely want to rule out the sacroiliac joint as a potential cause of pain, and that's something we'll talk about more in upcoming podcasts. History helps a lot to rule out spinal stenosis. And then obviously, is there a pinched nerve in the back? With an exam and a good history, usually you can tell the difference between those two pretty quickly. Um, uh, so, one of the other, I guess, patient populations where I might think of this a little more frequently would be someone who's had a fusion in the back uh, and having some back pain as well. Um, Fusions, as I'm sure we kind of touched on briefly, but so what a fusion would be, and now this model doesn't have it, but the surgeon would put a rod and screw kind of through the bone and through the bone, and then they'd connect it with a rod back here, and then they do it on both sides, and then that segment does not move anymore, right? So what patients will have after a fusion is the segments above or below will start to take up more of that work, right? Once one segment can't move at all, you got to get your motion from somewhere else. And that can increase the chances of arthritis at an earlier age, especially if that fusion was done in someone younger. So I see that a lot too.
When you see one of these patients, I guess when I see one of these patients, I guess the first thing I would typically do is if it's kind of newly painful, I might try a few medications, which, we've gone through in some of these other podcasts, typical pain medications. I might try a course of physical therapy, see if the patient can get some relief, um, and start there. And then if that doesn't work, tend to order some imaging after that. Um, and, the images that we typically order are x-rays and MRIs, which I think we've also talked about, and like we've said before, a lot of x-rays and MRIs, you might find a lot of things that don't really mean anything in regards to the patient's pain. We can certainly see arthritic changes in the facet joints when the patient has no pain, and we can certainly see no changes in the facet joints when the patient has pain related to those joints. So we don't really have a great study that we know of that can really localize where this pain is coming from. Would you agree with that?
Yeah, I would. I mean, yeah, I think in our daily practice, what we'll most commonly see is patients with pain kind of at the belt line, maybe a little bit below. Um, Typically, if we're thinking this is coming from the joints of the low back, it's usually the bottom two joints, right?
Right.
The L4-5 and L5-S1.
Yeah, I think that's
You know,
90% of the cases.
yeah,
So,
yeah. With the thought process, that's where most of the motion, gravity, weight, the wear and tear is going to occur. But you will see, and to your point with palpation, patients who do have some like upper lumbar facet issues, like the L1, 2, 2, 3, 3, 4, which is less common, like their pain will be a little higher up. And it's always nice, I guess from an imaging standpoint, I'll usually do X-rays. I usually have them standing, and bending forward and backwards with the x-ray just to make sure there's no abnormal movement of one bone on the other. Um, I don't always get MRIs for this. I think where there might be a role is, if it's not behaving like typical facet mediated pain, or there's some question, is this stenosis in somebody just without radiating leg pain at the time? And you might get some of those clues from the history. Um, and then also too, if you're looking for like an inflammatory type um, condition. So I think history will dictate the imaging I get, but I'll always do x-rays. How about you? Will you always do advanced spine imaging like CAT scan or MRI?
I'll tend to order advanced imaging, um, especially for chronic pain patients, just to kind of make sure there's nothing else there. I think that's kind of how I was trained, and how I think is, let's get the advanced imaging, make sure everything looks reasonable, and then move on from there. Because I don't know, I feel like X-rays tend to be pretty limited, but you can also make the argument that a lot of times on the MRI you don't really see that much that changes how you think about things. I think it is helpful sometimes. You do see sometimes some fluid in a facet joint on an MRI. I'll tend to lean towards that as my go-to joint, if I see that, if it fits with the picture. And there's definitely cases where, of course, you see fluid in joints that has nothing to do with pain, but if the fluid kind of fits with the patient's picture, I'll tend to lean towards that. I find that at least helpful and a little bit guiding. But I will tend to order um, MRIs for a lot of these patients. I've found that for X-rays, I used to order a lot of the flexion and extension views, but I didn't find that it was adding or changing anything in how I treated the patients. If they gave me a story that there was instability in terms of how they're feeling the pain and when they feel the pain. So I tend to think of those patients that have instability and pain related to the instability as patients who have pain with transitions. So transitions meaning after I sit for a little while, I go to get up and I get a really sharp pain when I'm standing up. And then once I'm up, I start moving and I feel fine. But in that transitional period, they have a really sharp pain. And the other really common one they say is that when they're laying in bed and they go to roll over, they get a really sharp pain when they roll over in bed. And those patients I tend to think of as the ones with kind of symptomatic instability. I understand. I think a lot of surgeons like to know if there's instability, if they're going to go in and do a surgery to see if they need to do some kind of fusion. But I haven't found that the seeing it on the X-ray really changes how I manage it. I guess I tend to manage that issue based on the patient's description of the problem. And that's just kind of an adjustment I've made probably over the last year or two, in seeing that I wasn't changing anything based on flexion or extension films showing movement there. Yeah.
Yeah, and that's a great point, and I would love to hear what you say to the patients about some of that, like the clinical instability that you just described. I guess the one thing that I'll use X-rays for with the Flex X views is if I do see a lot of movement, whether with flexion or extension, sometimes I get a little hesitant to do like a radio frequency in some of those patients. So that's kind of the one thing we'll kind of adjust maybe my potential treatment algorithm for them, which we'll get into in a little bit. But yeah,
I think we might be getting in a little into the woods for patients who don't know much about this. But one thing I will go back and say about what I just said is I see a lot of patients with instability that I suspect who haven't gotten a good treatment. And what I tell them is it's a mechanical problem and it requires a mechanical treatment. So a lot of patients want an injection to fix a problem. And when the instability is there, an injection doesn't fix that instability unless my injection was somehow going to lock that segment of the spine in place. It's not going to fix the problem. The problem is the instability that's there, which creates the pain. So we need to fix that mechanical problem with a mechanical solution. And we could probably have a whole, 2-hour podcast on spine instability and stability and the importance of that. But since I brought it up, just to briefly mention that the treatment for that specific problem, if we see instability, a lot of times is to stabilize that segment, which can be done through appropriate exercise, sometimes through appropriate bracing of the spine, sometimes through spinal surgery to stabilize the level. That I think that should, we can talk about that another time, I think.
So what happens? So you see the patient, you examine them, you've ruled out, a pinched nerve in the back, the sacroiliac joint. You've gotten some imaging. There's no bad central canal stenosis, and you're thinking, okay, this is pain coming from the facet joints. Uh, where do you go from there?
So I think what should be done is probably maybe not what is done in most cases, but what should be done probably is what's called a medial branch block injection. If we're getting to the point where we're going to try doing a needle to really, or placing a needle in the patient to really narrow down where the pain is coming from. So, like Dr. Connor brought up, the medial branch is the small nerve that carries the sensation from the joint, and there's two nerves that carry the sensation from each joint, and subsequently each nerve carries sensation from two of the joints. And so what we can do to really target the level is to do an injection of a small amount of lidocaine around a few of these nerves to see if we can make the pain sensation temporarily go away. And typically, like we said before, the most common levels are the two lowest levels of the spine, L4-5 and L5-S1. So a lot of times we would target the three nerves that cover those two joints, block those nerves, and then see if the pain temporarily goes away. What we ideally want to see is the pain goes away completely, and then the pain eventually comes back once the medication wears off. Do we see that all the time? No. Does the pain always go away completely? No. There's a chance there's other sources of pain or painful structures in the area, but maybe a significant portion of the pain goes away. But that's what we're looking for when we do that type of injection. I don't know if you want to show that again on your model there, where those nerves run.
Yeah, we can. So again, now that we're talking about patients who have continued pain after conservative treatment, and we're getting to the point where, okay, is there a spinal intervention that might be beneficial? The first thing is to truly diagnose and confirm that it's coming from these joints. And like Dr. Bonner mentioned, there's no imaging test that with 100% accuracy says the pain is coming from these joints. So uh, the best thing that we have is to actually do a diagnostic injection. And what we're doing here, and I'll show you on the model for those watching on our YouTube page, again, where the little nerve has been drawn with the black marker, right? So what we're going to do is we're going to actually, under live x-ray fluoroscopy, we're going to put a tiny needle. I'm going to show you from this angle here. We're going to put a tiny needle coming from the side and going to put it right down where that nerve runs. And we can see all that based on x-ray. Now we don't see the nerve itself, but we know the anatomy, and we could see these bony structures, so we know where it goes. So we would have the patient laying on their belly. We would come from the back, put the little needle in, under x-ray, use a little x-ray dye, make sure we're in the right place, numb it up, take the needle out. So with this, again, it's purely diagnostic. There's no steroid medication. This is not meant to last. And what we're really looking for is the response within the first couple hours. So I typically tell my patients, you have to come with pain, obviously. You know, I always have them try to aggravate it right before they come into the office. And then we'll do the test. Usually takes 10 minutes, usually 10, 15 minutes. We get them off the table. We try to aggravate their pain a little bit then, and then we give them a pain diary to go home with and to keep track the next few hours. Um, I think that kind of sums up the diagnostic process. And, this process should be done twice. And it should also, the importance of when the pain relief comes on, as well as how long it lasts, is also something that the clinician should be reviewing with you after you bring back the pain diary.
Yeah. So, and I think a lot of patients might say, well, why don't you just stick a needle in the joint and put the medication in the joint? And, that's something that we are pretty sure by now that we know that this kind of injection definitely doesn't have a long term benefit. It may have a small short term benefit, but um, injecting medication into these joints just has never been shown in a study to really provide long term benefit to patients with pain related to these joints. So we generally like to try these diagnostic injections because we know that if a patient responds well to the diagnostic injection, then we have this other treatment that Dr. Connor had previously mentioned called a radiofrequency neurotomy that can reliably treat the pain related to this problem. Whereas if we inject into the actual joint, get temporary relief, while it provides some temporary relief, it's not a long term solution. And it doesn't help us know whether or not we can do any other procedure to make the patient feel better in the long term. So, when we talk about injecting steroids or other medications into the actual facet joints, if you're a patient and you've been getting these procedures frequently and they're not helping long term, they don't tend to help long term, and so you shouldn't expect that. And if it did help long term, well, then you're one of the lucky ones who got one of the injections that happened to help you long term. But there is other treatment options available, and that's what we're hoping to make you aware of. And you could search out the other treatment option. Which, did you want to get into that next with the radio frequency procedure?
Yeah. I just wanted to touch base a little bit more on, the joint injection. So just like a knee, shoulder, hip, wrist, thumb, you can put cortisone in those areas with a small little needle, and you theoretically can put cortisone into these little joints. Um, just like Dr. Bonner said, when you look at the data and the research out there, there's no great research to support its use. Uh, I will tell you from a clinical standpoint that I will perform those injections on the specific type of patients, right? So, um, someone who is younger, doesn't appear to be disc related pain, I'll try a joint injection before I'll go down the road of determining if they're a radio frequency candidate. I'll try one. If it doesn't give them long term relief, 4 to 6 months, I tell them, we're not doing another one. Um, some patients who maybe are demented or just can't kind of really grasp the concept of the blocks and trying to figure out if it helps or not. And we're just trying to get them some relief because they're in agonizing back pain. Consider it. It becomes more of a challenge in older patients because those joints get real big and bulky. Here, I'll show you here. So again, on this model, easy to see the joint here, right? Nice big opening. But in people who have a lot of arthritis, this part of the bone right here grows over top of this joint. So it's really hard to access that joint with a little needle, nearly impossible in some cases. So yeah, I would agree with you. Routinely, if they're, 60, 70, 80, uh, steroid in the joint it's probably not going to do too much. Um, just to kind of be complete, there's some providers out there that will put other substances in the joints, whether it be like viscosupplementation, just like we do for the knee, to actually add a little bit of shock or like gel kind of substance between there to cushion it, or PRP, or even stem cell. I mean, these are things that are now being performed. Um, all we can really say is there's no evidence to support their use. Um, and especially if you're going to pay out of pocket for something, I would recommend you at least consider the proven method of treatment, which we'll talk about in a second. Anything else to add to that?
No, I think you made some great points. There are some definite practical uh, applications of a cortisone injection into the facet joints. And I think, you know, a lot of patients who might listen to this will have experience that, yeah, a lot of practitioners will do that cortisone injection, because if you do one and the patient gets great relief and it lasts really long, then great. It's probably, if they're relatively healthy, there's probably not too much risk of any kind of major adverse effect. And so it's kind of worth it to try that and see if there's any long term relief. And then if there's not, then you can proceed to kind of the diagnostic injection that we mentioned before. And then possibly um, the more definitive treatment, which we've been alluding to, is the radio frequency neurotomy. And I don't know if you want to go ahead and talk about that.
Well, almost. I think we just need to kind of clarify a couple other things with the medial branch blocks. And this is for patients who might be undergoing these procedures to pay attention to, so you can give proper information to your physician who's performing it, as well as to know yourself whether or not I should go forward with the radio frequency. So what I mean by that is usually two different anesthetic medications will be used at different times, right? So you come for the first block, you get the block performed, you go home, you keep track. uh, Ideally, the benefit should kick in within the first 30 minutes and last, depending on the anesthetic or the medication injected, somewhere between 2 to 4 hours, maybe 6 hours. Um, but if you don't see a drastic improvement within those first 30 minutes, and say you get the benefit 8 hours later or the next day, I'd be really hesitant to give any uh, uh, kind of credence to the block doing that. It could be a placebo response. Could have just been a better day for you. But so that's one key thing when you're interpreting the results of your own injection is, how did I do right away? We'll see some patients who kicks in right away, lasts the appropriate amount of time, then it comes back. We feel fairly confident that, those patients, that was an accurate test and they're going to do pretty well. Um, some I might see where it kicks in right away, but the benefits seem to last a couple of days. Have you seen that before, Dr. Bonner?
Yeah, or people who come back 2 weeks later and they say the pain never came back, and it's not really explainable by normal physiology, but it is what it is. It's a great, it's a therapeutic medial branch block, I think is what we always call it. And so that's, it's a great response. So
Yeah. What will you tell patients? So say they come in, they get the block done, they come back in the office, um, and they had 50% relief of their pain both times. So you did the first block, uh, they had their relief, they were able to do a little bit more. They did the second, but it was like 50%. What do you tell the patients with regards to, will you do the radio frequency? What are expected outcomes? All that.
I think if you have 50% relief from a medial branch block, it's, your expected outcome from a radio frequency neurotomy is not very good. It's a low percentage chance. We always go to conferences where they debate, how much relief do you need from a medial branch block to then go to a radio frequency neurotomy. Some people say you need complete relief of your pain with multiple medial branch blocks with different medications. And some people might use 50% as a cutoff, but basically all we know is that the stricter the cutoff you use, so if you use 100% relief, then the results with the radiofrequency neurotomy are more likely to be good results for the patient. But even in cases with patients who have 100% relief from multiple medial branch blocks, there will still be patients who go on to have the radiofrequency procedure and don't have relief of their back pain. And so as you go down with the percentage cutoff, you just get less and less likely to get relief. And I think if you get to 50%, you're getting pretty low. There's 30% placebo rate with any injection procedure. So if you're getting to 50% relief of pain, maybe you need to consider that there's another joint involved or some other source of pain on top of what you're dealing with. But you're probably not going to expect to have a good or great result with a radiofrequency procedure from that patient. What do you think?
I completely agree. I mean, every clinical context or situation is a little different, but I would agree with that. The data is pretty well out there, and it's been reproduced that the more relief you get with the block, the more successful the procedure will be. So again, my cutoff and ideally 80%
Yeah.
relief. Um, uh,
So
yeah.
isn't it?
So
It's probably one of the hardest parts about treating this problem is the medial branch block, because it's very hard sometimes for patients to understand the things that you were talking about, how the pain should kind of change very quickly after the procedure, but then the pain should come back relatively soon. And the patient wants to get treated. They want to go get the radio frequency procedure. That is the treatment that maybe you've explained to them that if they get to could produce long-term pain relief for them. So a lot of times they want to get to that procedure. And so they're biased in telling you their response to an injection that may or may not be helping. So it's very difficult to get, and it's not any fault of the patient. It's just that it's part of the problem with the procedure, is that they're the one giving the response. If we could give the injection and some computer was like, oh, you reduced the pain by 90% because it could sense the pain, then that would be way more useful than a patient who's really has been dealing with a problem for a long time, who wants to get the procedure. And they're like, oh, I think it's 80% better. And so sometimes it's just difficult to get very reliable responses. And it's just because, of course, patients want to get better from the procedure. And another thing is it's hard. It's hard to describe your pain sometimes. We talk about this all the time, but it's hard to get up after a procedure like that and then say, all right, well, is it different than when I came in? I think it's different. I think it's better. Is it in a different spot? We see a lot of patients struggling to figure out whether or not the pain is actually better. And if they're at all questioning it, then I'm very unlikely to push them to the next procedure. I There's a few patients I think of that, you did the procedure, they're laying on the table, and as soon as you inject around the nerve, they're like, pain's gone. It's gone. Like immediately they're like, that exact pain is now gone. And, those patients really seem to be the ones that respond the best. But that's not a high percentage of patients. That's a few patients here and there that really have that very, very, very specific pain.
yeah, and then to put on top of that, we always tell them, well, ignore the needle site pain. We just
Of
we
course.
just
Of
stuck you
course.
3 to 6 times, depending if we did both sides at the that same visit.
Right.
So, without a doubt, it's challenging, and the
Yeah.
best we can do is educate them on why we're wanting them to do this and why we're requiring them to do it. It's not just an insurance requirement, but it also does give us some great information with regards to where the pain is potentially and if it'll be successful.
Yeah, and the other thing is look, if it didn't work, it doesn't mean we just give up. We can try a different joint. We can try a different facet joint. We can try the sacroiliac joint. We can try other sources of pain. It's just a test, just like any other test, to give us information about where the pain is coming from.
So I think we talked a lot about it, and uh, you know, we've kind of touched on it already. But yes, so what is radio frequency ablation? Some you might hear it called radio frequency neurotomy. Some people might just describe it as burning my nerves. Um, do you hear it described anything else?
I think that's most common. Nerve. I hear patients come in. I had a nerve burning. Um, yeah, that's probably the most common thing.
So what it is those same little nerves that I showed on the model earlier. Instead of just numbing them up now and seeing how you do, we will actually heat them up. And when you heat the little nerve up, I always tell patients, you heat it up and then it kind of scars down, and it kind of blocks the pain signal from going from the joint to your brain, so you don't sense the pain. uh, I'll get the question, well, am I going to cause more damage because I can't feel it? My answer is always no. This is chronic pain. This is different than acute pain. The pain is not there to protect you. The pain now is just limiting you. Um, would you agree with that? I'm sure you get that question a lot too.
Yeah, definitely. I don't think I get it as much, but I definitely agree with your response. It'd be highly unlikely that you're not going to sense damage. We don't, what would we be worried about? What kind of damage would you cause to these joints or other structures innervated by the nerve? There's no common fractures of these joints in the lumbar spine, and so I wouldn't really be too worried about that in this case.
So it might be hard to project here, but I'll try. So again, our little model's back. This is the back part we're looking at. The dark lines there, again, are the nerves. So with a special needle, now this is not a radio frequency needle, but I'll show you anyway. With a special needle, we lay it down along the nerve itself. And the tip of the needle, when we hook it up to the machine, will actually heat up and cauterize that nerve. Um, so we have a whole protocol with regards to how high the temperature has to get, how long the burn has to be, and typically we'll do 2 treatments at each spot. So we'll do a little readjustment, and the whole purpose. And again, it might be very difficult on this. It might be too hard on this needle, but when you think about a needle, when it heats up, it'll heat up like the width of the needle on each side. So the bigger the needle, actually, the better it is for this type of procedure, right? Some providers will use a very tiny needle, whether it's based on comfort level or fear of injuring something. But if they're using a small gauge needle, whether I've seen 22s, I've seen 20 gauge, it's not creating that big of a burn, and your likelihood of a good outcome, even if you had really good blocks, is much less, compared to if you're using a 16 gauge needle, which is what I typically use. Some individuals will use an 18 gauge. Um, you know, bigger the needle, bigger the burn, better chance you have at really doing a good treatment.
Yeah, and just so patients know, um, a lower number gauge means a bigger needle, right? A bigger diameter needle. So as you're going down to like 18 or 16, those are pretty big needles to use, whereas 25 and 27, those are very, very small needles. Um, so uh, I think the really important points for this that patients should be aware of is how kind of particular these procedures are. So when you're doing the diagnostic injection, you have to put that needle right next to the nerve, like Dr. Connor showed on the model there. You have to put it right next to the nerve and inject very little medication, because if you inject a lot of medication, it spreads to other structures and it clouds the result. It could numb up other structures in the area, and then your pain may be relieved, but that's not because of the injection around the nerve. It's because some other structure that's painful was numbed up. So the same thing goes for the radiofrequency procedure. You have to put that needle directly next to the nerve. If it's not directly next to the nerve, when you turn on the radio frequency generator to increase the temperature, you're not going to burn the nerve. And if you don't burn the nerve, the pain won't go away. So these procedures extremely, it needs to be done extremely specifically right next to the nerve with the correct orientation of the needle pointing in the right direction. Because the other thing to mention is that it burns along the length of the needle. So if you put the needle tip right down on the nerve, you'll just burn like at the very tip. But if you put it along the nerve, kind of parallel to the nerve, then you can burn the kind of exposed tip length of the needle. And so we want to put the needle right next to the nerve, in line with the nerve, so that we can burn a long length of the nerve. And the longer portion of the nerve that you burn, we think the longer duration of relief of pain. And so we can't emphasize enough how important it is to have the correct technique when doing this. Um, there's been lots of debate over the years about the efficacy of this procedure, and a lot of that stemmed from studies that were done about this procedure. But then when they went back and looked at the images, the studies that showed negative results for this procedure didn't have the proper technique. And so if they didn't have the proper technique, you can't trust those results, because if the needle's not near the nerve's not going to burn, the patient's not going to get pain relief. Of course, there's a negative result. But they found that actually studies where the procedure is done correctly, there is a benefit to the procedure. So that's very important. Sometimes if you're seeing one provider and you've had this procedure, it may be beneficial to ask for the images so you could take them to someone else and just have someone confirm that they think the needle placement is appropriate. Like Dr. Connor said, we can't see the nerve. We just know where the expected course of the nerve is, and that's where we should put the needle, is in that expected course of the small medial branch nerve.
Yeah, I mean, these I would say are one of the more challenging type of procedures that we do, especially in patients with a lot of arthritis, or if you have underlying scoliosis or different issues. This could be very technically challenging, and you want to make sure you're going to a provider that uh, can complete can complete this the appropriate way. Um, so that's why Dr. Bonner and I, feel very strongly that if there's a procedure you've had that hasn't worked, and you wanted to figure out if it was done correctly, get the images from your provider, get the procedure report. We'd be happy to take a look and to let you know, because sometimes it's not done appropriately, and then that might lead you down the road of being prescribed opioid medications, or heaven forbid, even have to undergo a surgery where possibly, if you just had the procedure done the right way, um, could have saved you a lot of time and headaches. A couple of the things that I look for on reports that um, I think patients should be aware of too is, so just like you said, how much medication was injected and what did they inject is one thing on the test procedure. So if the doctor who's performing the procedure is also putting steroid in with the block, to me that's a red flag, because that just muddies the water completely. You don't really know if it's this general steroid effect, if you're feeling better or not. So to me, that procedure is useless. And then when you're talking about the radio frequency, um, temperatures and size of the needle. So we talked about the size of the needle, but temperature, right? Studies say it should be 80 degrees Celsius, right? Sometimes it'll be 85 degrees, but there's some patients or some providers out there that I've read their reports, and they're doing a low temperature burn at 45 degrees, which is called pulsed RF. There's no data to support its use for these types of nerves. So to me, that would be like you didn't really undergo any type of procedure, right? That's not going to work for you. And that shouldn't be performed, but it's out there. I've seen it. Um, so those are things to kind of look out for. Size of the needle, in my opinion, should be at least it should be a 16 gauge. If not, you can make the argument an 18 gauge should be burned at 80 degrees Celsius for at least 90 seconds, ideally. So these are things you could, talk with your provider about. Make sure they're doing these things. Hold them accountable.
Yeah, great. All great points there. I wanted to go back and mention one thing because we were harping on the how particular you need to be with the procedure. And like we did mention before, it's also possible the procedure is done 100% correctly and everything was perfect position, and you just don't get better. And sometimes we don't really know why. We don't know why you might have had a positive response to the medial branch block and then didn't respond to the radio frequency procedure. Sometimes it just doesn't work. And so that's also very possible. You may have a provider who's doing everything perfectly, and the procedure still just doesn't work in a subset of patients who respond to the medial branch block. So that's also very possible. And I've definitely seen that where you really just expect a patient to get so much better because they did so well with medial branch blocks, and then they don't get better at all. And you're like, what happened? Let's try it again. And then you try to like place everything perfectly again, and it like still doesn't work. And for some reason, there's that subset of patients that responds to medial branch blocks reliably and then doesn't respond to the radio frequency procedure. So it's very possible for you.
Yeah, it's frustrating as a provider because, right, we talk to the patients, we do 2 blocks, we do the radio frequency, and if it's on both sides, sometimes they'll do one side of the radio frequency at a time, come back. Excuse me. So you're seeing these patients frequently. They have a time commitment, and they're seeing you 3 to 4 times, and they get no better. It's definitely frustrating. But like you said, I mean, just like any other procedure, there's a failure rate, just like back surgery, just like hip or knee replacements. It could be done textbook perfect, and you don't get better. I mean, unfortunately, these things do happen. One thing that I've observed, and I'd be interested to hear your input, is in some of my patients where we didn't get the outcome that either of us hoped for or expected, um, we might then order advanced imaging. I might have did it with just the X-ray or a CAT scan. We'll do a little more investigating, and they will have pretty high grade stenosis in their back, like spinal stenosis. Um, so, one thing in the back of my mind always is patients with spinal stenosis, like moderate to severe, who just have back pain. Sometimes I wonder if it's more the stenosis, even though they're not getting leg pain,
Yeah.
than the arthritis itself.
Yeah.
What are your thoughts?
Yeah, I've definitely seen that. I remember one specific patient who I actually had him come in, and I said, okay, I wasn't clear on what the main problem was. He had, he had facet arthritic changes on the MRI, but he also had pretty severe stenosis at the same level. And I said, okay, come in. I'm going to inject the facet joints first, and I'm going to inject lidocaine into them and see if the pain goes away. So I had him, lay down, injected, got up, pain didn't go away. And so I said, okay, now I'm going to do a bilateral epidural. And I did a bilateral epidural injection and got up, and the pain was gone. So I assumed that his pain was more related to the stenosis than the facet joints. He also had a little spondylolisthesis at that level, which always makes me think about facet pain. But I was like, I was going back and forth between what the main cause of pain was, and after doing the facet injection with just lidocaine, or I may have done medial branch blocks, I don't remember exactly, but I basically just tried to do a diagnostic injection for just the facet joints, and I didn't see any benefit. And so then I had him the same day get on the table and I did a epidural injection to see if that relieved the pain, which an epidural is pretty non-specific, but I figured in this case I had done the more specific injection to rule out the facet joints. And so then I went to the spinal canal and I injected around the nerve roots there, and he had great temporary relief of the pain. So I assumed the spinal stenosis was more the issue for him.
Yeah. Um, and I would tell patients, if you know you have spinal stenosis, whether your physician showed you it or you're reading your report and it's moderate to severe and you have back pain and you are going to undergo medial branch blocks, and this is just speaking from experience at this point, I would make sure that your response with the medial branch blocks is really darn good, like maybe 100%. I would really err on the side of caution. I mean, even using, the 80% cutoff might not be enough in those cases. So I would really, you'd want to make sure all your pain's gone away during the course of that Novocaine type medicine. If it is, I'd feel a little more confident, but it can be tricky.
Yeah.
What do you tell patients? Is there any surgical fix for facet mediated pain?
If it is related to like the instability that we talked about before, then sometimes they could consider something to stabilize that level. I don't think I've ever sent anyone for that specific surgical procedure just for that problem. Um, you think theoretically you might be able to kind of fuse the facet joints and fuse the level to decrease the pain from those joints. Again, I've never sent anyone for that procedure. I'm sure that procedure's done, but I've never sent anyone. I've never had anyone who's wanted a surgery for the pain related to facet joints, from what I can remember, from suspected facet pain. I don't know how you feel about that.
Yeah, I mean, if it's pain coming from the facet joints and you've confirmed it one way or the other, as we talked about, I mean, I don't think there's a great surgery out there. I mean, you might feel better temporarily if you immobilize that segment, but there's going to be other issues down the road.
Yeah.
So I would agree with that.
Yeah, definitely.
What after the radio frequency, sometimes patients will have a little bit more pain immediately afterwards because we are heating things up. And what do you tell patients is typical response, and how do you manage some of that?
I think most of it's pretty self-limited. Occasionally, like you said before, I think patients with instability, I think I've seen a few people who maybe you create a little bit of instability during the procedure or just after the procedure, and they end up getting a little nerve root irritation and they get a new pain shooting down their leg after the procedure. I've definitely seen that a few times. And so, I tend to manage it just like any other, painful problem, but generally the pain should be pretty self-limited within a week or so. It kind of should be resolved. I think, especially in the low back, sometimes in the cervical spine, we talk about a little bit differently. Some of that may persist. You get that burning in the neck that may persist a little bit longer, but for the low back, it tends to be pretty self-limited from what I've seen. What about you?
Yeah, I would agree with that. Exactly. Self-limiting. I mean, I always tell patients you can almost feel like you have a sunburn type feeling or some discomfort. It could last a couple weeks. It will go away. A little ice. It shouldn't look sunburned by any means.
Yeah.
If it looks sunburned or there's concern for infection, obviously that's different. But you might feel some discomfort. And some of our patients who get the procedure done and they still have pain, one of the things you always want to make sure is it's not the sacroiliac joint below. There's actually an article out maybe within the last year or two that patients with what we're thinking is a failed response to radio frequency of the lower lumbar facet joints is actually just kind of unmasks the SI joint pain that was there, right? Like you mentioned before, maybe there is two things that are causing some pain. And we see sometimes like this driving force. So, it's this area, exam is consistent, we do things, but you're still having some pain. They come in and the pain is much lower. The testing for SI joint pain brings it on now. So I've probably seen maybe in the last year a handful of patients where that's the case, and then we'll treat the SI joint, and they'll do well then.
Yeah, I think if you're a patient listening to this, you want to make sure that your provider is constantly kind of asking questions and constantly seeking out answers with questions and examination. So if you do have pain that persists after procedure, maybe there was two things going on, and a good provider will keep looking for other things, or maybe you developed a new problem. That's possible too. So it's always important to know, for me, like, is the pain any different than before? Is it slightly different? Is it in a different place? Does it feel different? Maybe there's something different going on, or it's a different component. And just like you said, maybe there is something else going on at the same time. And so, if you're a patient and one treatment worked partially, keep pushing your provider to do more if it's possible. Okay.
Yeah, I think we talked and kind of touched on everything I was hoping to tonight. Was there anything else you wanted to kind of mention before we end here tonight?
No, I think we touched on all the major points here. So
again, you can listen to the podcast or watch the YouTube video. If you have any questions, feel free to leave comments in the YouTube section. Reach out to us via our social media or even our website. You could send us an email. We'd be happy to correspond. Again, our goal is just to educate and answer any questions you may have. So that being said, Dr. Bonner, have a great night, and we'll talk again soon.
Thank you for listening, and we hope you learned something beneficial. For more information or to schedule an appointment, please visit us at painconsultantsusa.com. You can also reach out to us at info@painconsultantsusa.com.